Hello! Welcome to the overview of the 2023 AGS Beers Criteria Microlecture 1. This will be the first of a series of 3 microlectures designed to give an overview of the 2023 AGS Beers Criteria. My name is Rebecca Bryn Yulson. I'm a board-certified geriatric pharmacist and School of Pharmacy faculty member at North Dakota State University in the School of Pharmacy. As we begin this presentation today, I would also like to acknowledge board-certified geriatric pharmacist and NDSU School of Pharmacy faculty member Mark Dewey, who also contributed content to this presentation. At the completion of this series of 3 micro-lectures, the participant will be able to identify basic principles of medication use in older adults, summarize the changes in the 2023 AGS Beers criteria, analyze patient cases to identify potentially inappropriate medications and understand their role in common prescribing cascades. Identify practical solutions to reduce potentially inappropriate medication use and polypharmacy for providers. When we discuss medication use in older individuals, it is important to remember that patient-specific responses to medications become more complex as patients age. We see changes in medication response related to altered pharmacokinetic and pharmacodynamic responses. For example, changes in stomach pH and decreased gastric mobility can affect medication absorption. Changes in volume of distribution can affect medication distribution and decreased hepatic blood flow. And first-pass effect can affect medication metabolism. Decreased renal clearance can affect medication excretion. In addition to changes in medication response based on pharmacokinetics and pharmacodynamics, older individuals are also at risk for inappropriate medication use due to adverse drug reactions, ADRs, polypharmacy, prescribing cascades, missing appropriate therapy, medication non-adherence, and inappropriate prescribing. Today, we'll define these terms further and discuss how the 2023 AGS Beers criteria can help to identify and address the challenges of using medications that are potentially inappropriate in older individuals. First, let's define polypharmacy. Quantitatively, there is no consensus on the number of medications. You can see the most common definition here along with the range of definitions found in the literature. The reference below does a good job of summarizing the literature on this topic. Often, we see numerous medications being prescribed for one patient by different prescribers to treat one or more conditions, resulting in medication overload. It is important to note that polypharmacy and polymedicine, or beneficial polypharmacy, are not the same. This next slide helps to better visualize polypharmacy. When polypharmacy is beneficial, we see necessary medications being prescribed where the medications are indicated, and the benefit of use is greater than the risk of use. Medications in this category continue to remain necessary, indicating that there is continued assessment of appropriateness. Likewise, OTC and supplement use are also necessary. When we see polypharmacy resulting from medication overload, we may see medications prescribed that were never necessary, medications that may be indicated, however the risk of use now outweighs the benefit, medications that were once necessary but are no longer needed, and unnecessary OTC or supplement use. Potentially inappropriate medication use may result from prescribing cascades, which can also contribute to polypharmacy. According to Sternberg and colleagues, quote, "A prescribing cascade refers to the sequence of events in which an adverse drug event is misinterpreted as a new medical condition, leading to the addition of another, potentially unavoidable medication." End quote. In 2023, the American Geriatric Society, AGS, updated the AGS Beers criteria and published the update as a special article in the Journal of the American Geriatric Society. The citation for this article is on the screen before you. This article is an evidence-based guide for practicing clinicians to identify potentially inappropriate medication (PIM) use in patients 65 years and older in ambulatory, acute, and institutional settings. It is noted that these guidelines do not apply to settings where patients are in hospice or receiving end-of-life care. The Beers criteria, first published by Dr. Mark Beers over 20 years ago, focused on frail elderly in nursing homes. Over the years, it evolved from criteria Dr. Mark Beers updated to a list of criteria supported and maintained by the American Geriatric Society, AGS, which is updated approximately every 3 to 4 years that includes 5 general categories organized in various tables that includes, in addition to recommendations, rationale, quality of evidence, and strength of recommendations. The AGS Beers criteria. Potentially inappropriate medications are an explicit list of medications that may be inappropriate for older individuals given medication-specific characteristics, drug-drug interactions, and/or drug disease or drug syndrome interactions. These are not absolute contraindications, but rather opportunities to pause and consider if safer alternatives may be available. They are potentially inappropriate. There may be barriers to therapy, for example cost, or failure of a safer alternative that may warrant use of these medications. Visually, it can be helpful to think of potentially inappropriate medications as the yellow light on a stoplight. In the 2023 AGS Beers Criteria Update, there is a new table. Table 11. Principles for how patients, clinicians, health systems, and payers should use the AGS Beers criteria. These principles are worth reviewing specifically. I am going to quote each of these principles directly as they are outlined in the table. First, as we previously discussed, quote medications in the AGS Beers criteria are potentially inappropriate, not definitely inappropriate. Read the rationale and recommendation statements for each criterion. The caveats and guidance listed there are important. Understand why medications are included in the AGS Beers criteria and adjust your approach to those medications accordingly. Optimal application of the AGS Beers criteria involves identifying potentially inappropriate medications and, when appropriate, offering safer non-pharmacologic and pharmacologic therapies. Quote, the AGS Beers criteria should be a starting point for a comprehensive process of identifying and improving medication appropriateness and safety. Access to medications included in the AGS Beers criteria should not be excessively restricted by prior authorization and/or health plan coverage policies. End quote. The final principle from this table references differences in applicability of these recommendations in other countries due to drug availability differences that may exist. The methodology used to update the 2023 Beers criteria is as follows. A comprehensive literature review of data published between June 2, 2017 and May 31, 2022 was used to guide recommendations. Medications were removed if they are no longer sold in the U.S., if potential for harm is not unique to older individuals, or if medications were considered low use. Low use was defined as less than 4,000 U.S. Medicare beneficiaries aged 65 years or older, receiving the drug in 2020 based on data from Medicare Part D public use files. The 2023 AGS Beers criteria are organized into 5 tables with the following titles. 1. Medications considered as potentially inappropriate, Table 2. 2. Medications potentially inappropriate in patients with certain diseases or syndromes, Table 3. 3. Medications to be used with caution, Table 4. 4. Potentially inappropriate drug-drug interactions, Table 5. 5. Medications whose dosages should be adjusted based on renal function, Table 6. The quality of evidence ranges from low to high, and the strength of recommendation ranges from weak to strong. With that, let's highlight some of the new and/or updated recommendations in the 2023 AGS Beers criteria, considering items in Table 8, quote, medications criteria removed since 2019. AGS Beers criteria, end quote. Table 9, quote, medications criteria added since 2019, AGS Beers criteria, end quote. And Table 10, quote, medications criteria modified since the 2019 AGS Beers criteria, end quote. Note, the recommendations reviewed in this series of microlectures will not be comprehensive, and participants are encouraged to review the 2023 AGS Beers criteria to assure that they understand the recommendations surrounding medications that may be more commonly used in their practices. It is also important to note that the medications discussed as highlighted new and/or updated recommendations may be changes to one table only, and the medications may have other recommendations that appear in other tables that did not require updating with this new publication. First, we'll start with additions to Table 2, potentially inappropriate medication use independent of diagnosis or condition. In this category, we see, quote, warfarin for the treatment of non-valvular atrial fibrillation or venous thromboembolism, end quote, has been added. The rationale for including warfarin as a potentially inappropriate medication in these scenarios is based upon current clinical practice guidelines, recommendations for non-valvular atrial fibrillation and venous thromboembolism, as well as safety concerns with bleeding risk. According to the 2021 updated CHEST guidelines, antithrombotic therapy for VTE disease and 2023 ACC, AHA, ACCP, HRS guideline for the diagnosis and management of atrial fibrillation, direct oral anticoagulants are the preferred choice for anticoagulation for many individuals with these conditions. When starting a patient on a new agent, it is reasonable to avoid warfarin unless there are significant barriers to use, contraindications, or other concerns with direct oral anticoagulants use. This is a strong recommendation with high-quality evidence. We'll discuss the differences between direct oral anticoagulants and do a case study in Microlecture 2. A question you might ask is, does this mean if someone is on warfarin for atrial fibrillation, would we automatically change them to a direct oral anticoagulant? Not necessarily. As you can see, if an older adult has been using warfarin and has a history of being in a therapeutic INR range without adverse effects more than 70% of the time, it may be reasonable to continue to use warfarin. There are also other considerations to take into account when selecting an appropriate anticoagulant. Cost can be a barrier to direct oral anticoagulant use for some patients. Frailty is another consideration where age, weight, renal function, adherence, and dietary habits can influence choice of anticoagulant and dose. There is a case report article that was published in the Journal of the American College of Cardiology in November 2024 by Dr. Justin Lee, titled Anticoagulation in Atrial Fibrillation Patients with Frailty, that discusses these considerations in greater detail. An article published in Circulation in January 2024 by Justin and colleagues titled Safety of Switching from a Vitamin K Antagonist to a Non-Vitamin K Antagonist Oral Anticoagulant in Frail Older Patients with Atrial Fibrillation. Results of the FrailF randomized controlled trial found, quote, in this pragmatic randomized trial in older patients with atrial fibrillation living with frailty, more major and clinically relevant non-major bleeding complications were observed when switching from vitamin K antagonist treatment to a non-vitamin K antagonist oral anticoagulant, compared to continuing VKA treatment, end quote. There were limitations with this trial, so while it adds to the literature, it is not able to answer many questions related to risk and benefit of vitamin K antagonist versus non-vitamin K antagonist oral anticoagulant in frail adults with atrial fibrillation. There are other trials and factors to take into consideration, along with this trial when making recommendations for patient care. The citations for both of these articles are at the end of the PowerPoint presentation. I would encourage you to read these articles and associated commentaries for greater insight into this topic for this specific patient population. Next, we have additions to Table 3, potentially inappropriate considering disease and syndromes. In this category, we see 3 additions, 2 on this slide and 1 on the next slide. The first is dextromethorphan-quinidine. In heart failure patients, this medication should not be used due to concerns related to QT prolongation, and in fact, the package insert lists heart failure is a contraindication to use. This medication is also listed in Table 4, drugs to be used in caution with older adults. The second is the potential for opioid administration to result in delirium, leading to the recommendation to avoid use. Quote, except in situations listed under the rationale statement, end quote. Under rationale, we see the following statement, quote, for older adults with pain, use a balance approach, including the use of validated assessment tools and multimodal strategies that include non-drug approaches to minimize opioid use. This is a strong recommendation with moderate quality evidence based on emerging clinical evidence. Note, opioids are also mentioned in criteria in other tables as well, and I would encourage you to also review these criteria, rationale, and associated recommendations. Finally, under additions to Table 3, we see anticholinergics being identified as medications that should be avoided in individuals with a history of falls. This is a strong recommendation with high-quality evidence. Table 7 in the 2023 AGS Beers criteria lists medications with strong anticholinergic properties. It is important to note that while anticholinergics were added to this table specifically in this update, anticholinergics are also identified as potentially inappropriate medications in Tables 2 and 5. I would encourage you to also review these criteria, rationale, and associated recommendations to avoid use. Next, we have additions to Table 4, use with caution. The first new medication added to this table is ticagrelor. The rationale behind adding this medication due to increased risk of bleeding when compared to clopidogrel, quote, especially among those 75 years old and older, end quote, which is why the recommendation for cautious use includes a specific caution for adults 75 years of age and older. The second addition to this table is the sodium glucose cotransporter 2, SGLT2 inhibitors. The rationale for this, quote, increased risk of urogenital infections, end quote, especially in female patients during first month of being treated with these medications. There is also, quote, an increased risk of euglycemic diabetic ketoacidosis, end quote. The recommendation, therefore, is to use with caution and monitor patients for both potential complications. This is currently a weak recommendation with a moderate quality of evidence. This concludes the first AGS Beers criteria microlecture. This slide provides the references for the presentation. Please continue to the second AGS Beers criteria microlecture. Thank you!